Dr. Vandana Siroha ma'am, Gurujans, I welcome you all in another intellectual session of Gyan Ganga webinar series. Today's guest speaker is Professor Dr. N.V. Sreevaths, MD IU, CRAV Guru, Palakkaad, Kerala, who has joined us today in the 248th episode of this knowledge voyage. I, Dr. Saraswati, on behalf of RAV, welcome you all for today's session. On the onset, we would also like to express our heartfelt gratitude and welcome our mentors. Sir, can you please mute your mic?
आपको सभी औषधि वहां प्रत्यक्ष करके बताएंगे और यहाँ पंचकर्म का भी पूरा ज्ञान देंगे। अभी तो जस्ट पंचकर्म का सीजन खत्म होते आया है।
On the onset, we would also like to express our heartfelt gratitude and welcome our mentors who have always been there to guide, motivate, and encourage us for sustenance of this series. Respected Vaidya Shri Devendra Trigunaji, President of GB, RAV, Respected Vaidya Shri Rajesh Kotecha Sir, Secretary, Ministry of Ayush, Respected Dr. Vandana Siroha Ma'am, Director, RAV. Let us begin the session by seeking the blessings of Lord Dhanvantri. Om Dhanvantraya Namaha. Now, I would like to introduce today's expert, Professor Dr. N.V. Sreevaths Sir.
अपन सब मिलके सतत अध्ययन सीखें। एक
Who
बार
is going to
सिर्फ सीखने के लिए आए हैं, तो ज्यादा फालतू टाइम वेस्ट न हो इसका ख्याल रखें और एक एक क्षण महत्व होता है, एक एक दिन महत्व होता है। हर रोज कुछ न कुछ सीखने का प्रयास।
Sorry for the disturbance. Now, I would like to introduce today's expert, Professor Dr. N.V. Sreevaths Sir, who is going to throw light on the topic, role of Ayurveda in management of cancer training. It is my proud privilege to introduce Dr. N.V. Sreevaths Sir, an eminent Ayurveda physician and academician par excellence. Dr. N.V. Sreevaths is a distinguished Ayurvedic physician with over 32 years of extensive clinical experience, specializing in Asthi Marma Chikitsa and musculoskeletal disorders. He holds an MD in Ayurveda from the University of Kerala. He has served in several key academic and administrative positions, including senior specialist in the Department of Indian System of Medicine, district program manager under the National Ayush Mission, and principal and medical superintendent of Rajiv Gandhi Ayurveda Medical College. He is founder of Swasthya Kshetram Ayurvedic Healthcare Center, Kerala, and has over 15 years of teaching experience as lecturer, professor, and principal. Dr. Sreevaths has made significant contribution in research, publications, and national level training programs and is widely recognized for his expertise, receiving multiple prestigious awards and serving as a resource person in numerous academic and professional forums across India. Now, I would like to invite Sir to proceed with the lecture. And before we start the session, I request you all to please switch off your mic and cameras. Sir, you may start the session.
Thank you, Dr. Garima. Hope I am audible.
Yes, sir. Yes, sir.
Namaste to all. Namaste to all Gurujanas who are here. At the outset, let me thank the Rashtriya Ayurveda Vidyapith to have given a chance for addressing this occasion. I pay my utmost respect to the Secretary of Health, Ayush Kotecha Sir, Targunaji, then our director, dear Dr. Vandana Siroha, and all the officials in RAV, as well as all my senior gurus, my Vandanam, my respects and regards to all colleagues over here. This is the 248th session of RAV webinar, which itself shows the commitment of the organization towards spreading of the knowledge of Ayurveda amongst the gurus as well as the shishyas who are enrolled in this RAV program, CRAV program. And this also reaches other people in the field of Ayurveda as well as the scientific society. So this is a very good opportunity. Hence, I thank once again. And in this session, I wish to share some aspects of management of cancer pain. Actually, I am telling about something which I did for my postgraduate studies in the Regional Cancer Center Trivandrum when I was studying in the postgraduate course in Trivandrum Ayurveda College. So I thank all my gurus and guides who guided me over there and who opened a new area at that time when palliative care was just taking the first step. I was able to do it, and now we see that Ayurveda oncology is a very big branch, and there are very, very proficient practitioners amongst us who do wonderful job. And I am glad that this subject is being taken up for discussion in a big way. Let me share the slides. Shall I share the slides?
Yes, sir.
I think is it visible?
No, sir. Now it is visible, sir.
It is okay, I think, no? Full.
Yes, sir. Yes, sir.
Okay. So, anything in between? Dr. Garima, please inform me so that I can.
Sure, sir. Okay, sir.
So we are talking about the role of Ayurveda in management of cancer pain. Now, so two things are there. Now, what is there? The definition or the viewpoint of Ayurveda regarding cancer, especially different types of cancers are there. And as far as Ayurveda is concerned, we know that some of the cancers may be Rakta Pitta, some of the cancers may be Granthis, some of the cancers may be Gudma. They show different characters, but when we read through the Samhitas, the Arbudhavastha occurs as a last stage. When we compare, when we learn from Jara to Rakta, Vata Rakta, then we see that the involvement of the Dhatus are there, which go into a very difficult stage called Arbuda. So, we discuss about the Arbuda and then cancer pain. Now, generally pain management, everything we are talking about, what is the difference between ordinary pain, simple musculoskeletal pain. As a Marma physician, I am dealing with all injury pains or any connective tissue, musculoskeletal pains, neurological pains, etc. But what is the difference between cancer pain when we approach the patient? So this topic also, and I will share some of the findings of my work, which is a very preliminary work, and I think some of the RIV Shishyas may be prompted to work on this. Another opportunity is that we will be discussing an agent which I used, which is in the Siddha system of medicine, commonly used by Ayurvedic practitioners in Kerala also, Rasagandhi Medug, it is called. So my study was a very good integration of all these things, including the what we call now as integrative medicine. So let me begin. Okay. Now to open it, I would like to quote Dr. C.D. Deshmukh, Chairman UGC in 1957 itself. If we recapture some of the ancient spirit of investigation and the detailed painstaking observation in the search of truth, there is a great deal of scope for us to review, some of the ancient achievement of which we are justifiably proud. We must strive our best to bring out what is hidden in our ancient heritage. This statement was a great kickstart for me, because what we have in Ayurveda, it has to be brought out, and that will be very much, it's a big scope that some of the achievements are now we will be able to showcase for the modern world now. So The problem, Arbuda is not a local disease which can be disposed of by excision. If we take it as a Granthi and Arbuda, etc., which is a Mamsankura or just like that as told, then we see that even after excision of that mass, the problem is not solved. So it is not a thing which can be disposed by Chedana itself. The treatment of Arbuda consists of Shastrakriya, Agni Karma, Aushadha Chikitsa. Now if you translate it, now Agni Karma is chemotherapy or Aushadha Chikitsa is the most, the different types of biomedical agents which are used, and Rasayana Chikitsa, now we have gone for the immunotherapy also, corresponding to radiation therapy, chemotherapy and immunotherapy in modern medicine. So here we introduce one more thing which I was very glad to do is the palliative care. And we have the Apya Chikitsa, that is until the lifespan is there, we have to support the patient and see that his health is as good as possible. So that is the Apya Chikitsa. So palliative care also is aimed at, we cannot translate. Hello?
Hello, yes, sir. Sorry for the You can continue, sir.
It is okay, no?
Yes, sir, it's okay.
Palliative care, Apya Chikitsa is done when it is incurable. The slides are moving, no?
Yes, sir, it is moving.
Okay. The need, why we should do a study on cancer, its relation to Ayurvedic concepts, etc. Cancer is more than a cellular dysfunction. It is a historic event, a conceptual bias, a social, economical and ethical dilemma. It raises special issues in clinical management such as refractory pain, severe malnutrition and rehabilitation challenges. Now that itself will show how much Ayurveda as a holistic system can help a cancer patient. One of the primary tasks is to comfort the dying and relieve their suffering. This will be a punya karma which we are doing when the patient do not have any cure, but he has to be cared for. The significance, it is almost impossible to achieve a satisfactory loco-regional control in many patients with the available methods of treatment. Here, local and regional control means the local area where the Arbuda is there, and the regional is the lymphatic circulation or lymphatic system which is regional to that place. The head and neck cancer pain has an added dimension due to the psychological aspects of the visible tumor that can be perceived always. Now consider that one person is having a tumor on the face, for example on the lips, on the buccal cavity or on the cheek. It shows out, whereas any cancer inside the stomach and all may not show out. So this has a psychological aspect because of the visible tumor, and everyone will be seeing it, like what we tell in dermatological conditions, no? Like that. So the search, many herbomineral preparations from Siddha systems is used by traditional physicians of Kerala to treat chronic disease conditions like cancer. Investigatory research should be done to prove or disprove the claims as well as to understand the problem in depth. Here I would like to quote that even a very senior professor in Kottayam Medical College, Dr. Charyan, he was using many of the medicines which are told in Ayurveda and Siddha for curing cancer as well as giving us palliative agents. So that was also an inspiration in 1989 when I did this work. Head and neck cancers of CNS excluded. So whatever is there in the central nervous system, it is not considered under head and neck. They are understood separately. Stress laid on cancers of oral cavity. Majority of tumors are accessible, that you can see it or you can reach it or you can examine it, etc. Slow to develop or metastasize. They are usually slow to develop or metastasize. So it is not very, very fast as in some bloody discariasis. Require long-term care. Affects speech and swallowing usually. See, once it is in the mouth, you can see that if we talk from my marma point of view, it will affect the marmas in the face or head and neck. There are 37 marmas we know. So whichever now, if the Nila Manya is affected, speech, swallowing, taste, everything will be lost. Disfigurement due to tumor or treatment. Recurrence necessitating further treatment. So all these things have to be considered. Now, Urdhva Jatugrada Arbuda, especially Muga Arbudas, when we compare, Muga Rogas which can turn cancerous are Vada Pitta Kavaja Jihvas, that is Tridoshaja Jihvas, Mamsa Jihva, Jihvalasa, Upajihva, Adijihva, Kantashunti, Tundigeri, Kalu Kachaba, Rakta Arbuda, Mamsa Sanghada, Uppuda, Talu Shosha, Talu Paga, etc. Kapola Arbuda is mentioned already. In some Tamil textbooks we have, or ancient Malayalam textbooks we have mention of Kavil Varp and Putrunoi. Putrunoi is Tamil version of it. So palliative care, when we discuss about palliative care, I told that it can be compared to the Appichikitsa. It is the active total care of the patients whose disease is not responsible to curative treatment. So we try to cure, but we see that the sadhyavastha is still, it is not at all there, and it become anupakrama. So then the patient has to be totally taken care of so that some relief can be given for his pain and other things. Its goal is to achieve the best possible quality of life for patients. So here we study about the QOL, or the performances or the quality of life, which index is there, so that any disease which is not possible to be cured, we at least have to improve the quality of life. When a Vaidya's intervention should improve the quality of life. It neither hastens or delays death, and it should not be to delay the death or hasten the death, because both have ethical issues. It provides relief from pain.
Excuse me, sir. You are not audible.
Yapya Chikitsa helps the patient to have his full life by means of strict regimen in that state. So there is Patya Apatya which has to be followed in the state, which gives him better opportunity to manage the symptoms. Helps to get relief of distressing symptoms and prevents relapse or recurrence, the disease being deep-seated. Now, approach to the symptom relief and palliative care, actually the patient, we have to communicate with the patients, that is darshana sparshana prashnaihi, like observation, listening, talking, awareness. Then he has to be made aware of the thing that it is a place where we have to play a role of palliative care. So there will be an immediate response, then they have to acknowledge that, then we have to reassure, and then assessment options we have to see, and then decision has to be taken, then the decision has to be modified, and then assessment, and again go to the patient and what to be done. Like Acharya tells that Sukshma Samiche Isham, Dosha Aushadha Nirupane, it has to be done, and then it comes back to the patient or application in the patient. Shastra, we know how to do the Vyavahara. As far as common treatment is concerned, we know that in palliative care, what is the most suitable thing, that should be Vyavahara should be done. Approach to symptom relief and palliative care, undertake a logical sequence of action, that is what we told, reassurance, provide information needed to make decisions on pain management. The patients, though if the patient cannot be informed, the bystanders or the family members of the patient has to be informed properly whenever you take a decision and for what the decision is taken. Prompt action has to be taken, produce results. Some results should be there, because in the name of palliative treatment, if you are doing something and there is no effect on the quality of life of the patient, then that is useless also. So enhance patient's feelings of respect and control. Always we have to respect the patient. He cannot be called just a case. So have a very personal rapport and improve the communication. Excuse me. Terminal care. What is terminal care? Refers to the management of patients in whom the advent of death is felt to be certain, where medical effort has turned away from cure to care. That is terminal care. The diseases are incurable and immitigable in Pratyakaya Vyadhyavastha. Affection towards the sick and dying patient is stressed in Ayurveda very much. That's why we tell that Agantam Pranam Sutta. he has to be cared for. Now, pain and concept of total pain I am coming to, because Ruja, we know that we will be talking about it. Total pain includes the noxious physical stimuli that we know that the abhiga, anything from outside, psychological, social, economical, and spiritual factors. This physical stimuli includes the biochemical stimuli also within the body. Unrelieved severe pain is often associated with disturbed sleep, reduced appetite, impaired concentration, irritability, and depression. So we can see that when the pain is very severe and it is not, you are not able to relieve pain by all the methods, or painkillers or any other methods, then it will go for mental disturbances. That is in Marma we usually refer about the physical pain leading to mental pain. Mental pain will become a chronic pain like. So it becomes disturbed sleep, reduced appetite, impaired concentration, irritability and depression. So we know that there is the increase of Vata and the effect of Vata in the Manas. It becomes a more of Manasika Avastha over there where counseling is also required. Now, the causative factors of the pain will be past memory of any pain. If you had any pain, that will come to your mind. The patient will suffer from that. Motor activity, any movement, if it is causing disturbance, it will cause pain. Noxious stimuli, again, biochemical situations. Emotional state. Already the patient is suffering. At that time, if there is a family loss, member loss or anything, that emotional, or there is nobody to care for, that emotional state also will increase the pain. Other sensory output also increases or contributes for the pain. Pain is a common problem in cancer patients. Cancer patients in pain exhibit a mixture of both fight or flight and vegetative responses. So you can see that sometimes they will want to fight it out, like reactively responding to it by asking for remedies, etc., or flight, or they want to escape from it by other methods. The patient realizes that he is on a collision course with death. Already he knows, if he knows that he is having cancer and is going to die, so his thoughts of always the death, there is collision course with death, it is called. So that gives a very bad mental situation. Some who are prepared, who are Sattobala, who know that they are going to die and they will pray for their moksha and die. That is a different thing. But generally, the public, the human beings are of the Madhyama Sattva or the Alpa Sattva. So there always has a chance that they go for depression. It is distinct from chronic pain of non-malignant origin and also from acute pain. This is what I was stressing upon, that this malignant cancer pain is distinct from chronic pain and acute pain. How, if we have to discuss, then we can see that later. Classification of cancer pain patients, usually one group is patients with acute cancer related pain, patients having tumor associated pain, patients having cancer therapy associated pain. Now group 2 patients are patients with chronic cancer related pain, having chronic pain from tumor progression, tumor is increasing in size, so due to that, having cancer pain associated with cancer therapy. Group 3 patients with a history of chronic non-malignant pain who develop cancer and pain. So already patient is having a painful situation where he develops a cancer also. Dying patients with pain, that is the next stage. So here you can see the nature of cancer pain is there, preempts attention, then when it becomes unrelieved, the patient develops anxiety, loneliness, fear. This is a vicious circle. Anxiety, more of anxiety, more of loneliness, and more of fear of death. Then isolates himself, patients and family and staff. See, slowly he gets isolated, or family and staff also, once we get into a situation that the patient cannot be saved, isolates the patient. Now, this is what I told, difference between acute and chronic pain. In acute pain, the conduction pathway is rapid, and chronic pain, it is slow. The tissue injury is clearly causal in acute pain and minor or absent in chronic pain. So in tissue injury will be there, usually that will lead to acute pain, but in chronic pain it need not be there. Automatic response is present in acute pain, absent in chronic pain. Biological value is high in chronic acute pain and less in chronic pain. Here itself we can see that when we relate Ayurveda, immediately after Abhigada, when the Chadoshma is there, Vata is increased, the pain will be more. When it after some time the pain decreases on its own because there is an adjustment within the body, and once it becomes chronic it is quite low. Or we see that in age also. In young people it will be high, in old people it will be low. Mood, anxiety will be there in acute pain, whereas depression and anxiety will be there in chronic pain. Social effects are very slight in acute pain because it is accepted that it may relieve in 1 or 2 days. But in chronic pain, it becomes marked because everyone the patient meets is going on telling that he is having pain, he is suffering from pain, etc. Effective treatment in acute pain is analgesic, but not in chronic pain, which may be variable, sometimes more than just an analgesic. Now, this is very important for an Ayurvedic, from the Ayurvedic point of view, when we see the patient holistically. Physical and mental factors which modify pain, threshold and response to pain. I remember the great Dr. Rajagopal sir of Koilon, who guided me in this aspect, that he told me that don't search for any painkiller as such. Even Sholagna Gana will be is there, Vedara Stabhana Gana is there. But you have to understand that many of the situation pain is the karana will be different. So you attack address the karana and then you will get pain relief. Every time pain need not be given a painkiller. So this has helped a lot in management of such conditions. So threshold is lowered by anorexia, that is when the Agnibala is less, fatigue and lassitude. I'm not translating, I'm going on like that. Constipation, diarrhea, nausea and vomiting, dryness of mouth and dysphagia, inflammation and edema, ischemia and ulceration, anxiety, fear and anger, depression and sadness, mental isolation and introversion, immobility. So all these things. So when the patient is alpabala, he is having vidbandha or he is having atisara, he is not able to ingest food, he has shofa, he has Raktakshaya, or all conditions will lead for lowering the pain threshold. So it increases the sattva, and so pain cannot be tolerated. Whereas sleep and rest, sympathy and understanding, diversion, elevation of mood, all will relieve the pain. This is what we do many times when we get patients with severe pain, I think. Every Ayurvedic doctor has been tuned to have the Purva Vibhashi, Sumugha, Sushilaha, Karuna Mrudu, the Karunya we show, the Mrudutva in which we address the patient. All this will reduce the pain. Now, diagnosis of the pain-related history should be taken, medical history should be taken, psychological history should be taken, physical examination should be done, and confirmatory radiographic and laboratory procedures, if it is required, has to be done. Classification of pain, related psychological dysfunction, related social dysfunction, related physiologic and medical conditions, all this should be taken into account, and then pain diagnosis have to be done. So here we will be able to tell whether it is a acute pain, chronic pain, or it is a cancer-associated cancer pain. Therapies for organic components of the pain has to be done. Therapies for psychological component of the pain and related disorders. Here I bow down to our acharyas who have told that the chikitsa is threefold, that is Yukti Vipashraya, Deva Vipashraya and Sattva Vijaya. So in normal clinic itself we see that we are using the Sattva Vijaya along with Yukti Vipashraya to become a successful physician. I am not going to tell about Deva Vipashraya, which is also important as far as a Karmaja Vyadhi is concerned. Subjectivity of pain, measurement of pain, whether pain can be measured, it's a subjective symptom. Subjectivity of the pain makes it assessment difficult. Different methods used are VDS, it is called verbal descriptor scale, whether it is very severe, less severe, or moderate, or very little. Like that verbal analog scale, we would have all seen 1 to 10, it will be marked. Chambers Price Pain Rating Scale, Johnson's 2-component scale, McGill pain questionnaire and card sort method. These are different things are there. My guide in regional cancer, he used to use the coin method, like a big 1 rupee coin, then a small 50 paisa coin, then a small 25 paisa coin. So every time when they come for assessment, how much was the pain last time, how much is it now? So that is the measurement of pain. Now, approach to management of cancer pain from the modern point of view as well as Ayurvedic point of view, we have to see pain initial therapy there in modern symptomatic, which may include non-opioid analgesics, adjuvant drugs, weak opioid analgesics, local anesthetic blocks, physical therapies, psychological therapies. Anti-cancer, which may include radiotherapy, hormone therapy, chemotherapy, and surgery. If pain persists, continuous and modified use of strong opioids or non-opioid and other adjuvants are used. Pain persists localized or unilateral, neural block or destruction of pain pathway. Continuous comprehensive care in hospital or at home should be given. So there are different stage situations where if one fails, the other thing has to be done. Now we will move to the WHO has a 3-ladder proposition where you start with non-opioid analgesics, then go for semi-opioid and then the morphine or opioids. Now Ruja or pain is a samanya lakshana of all vyadis. It is manifested due to Vikrita Vata. It indicates a general sense of uneasiness which is applicable almost to all diseases. Now if we translate it as Vedana Visheshas are many. So synonyms are Shula, Toda, Vedana, Vyata. It may occur as Lakshana or Upadrava. Here I remember, recollect the Vikrita Lakshanas of as told by Vagbhadacharya. It can be when the pain can be classified into 4 or 5 in modern, like stabbing pain, piercing pain, throbbing pain, etc. Our Acharya has given variety of the pains like Samsa, Vyasa, Vyata, Swapa, Sada, Ruk, Toda, Veda, Sanga, Angavanga, Sankocha, Varta, Harshana, Tarshana, Kampa, Parushya, Saushirya, Shosha, Spandana. This much of Vedana Vigaras have been given, which gives a bigger umbrella of presentations as far as the cancer pain is also concerned. Arbudaruja or Vranaruk is a major complication in Vrana in many avasthas. It can occur in Arbuda also. So Vranaruk, when we see the Vrana chapter, we can discuss about Vrana. In Vrana Upadrava, there is one main Upadrava called Vranaruk. It can occur in Arbuda also. The severity depends on the Sattva Bala of the patient or the capacity of tolerance. Now, we saw the factors which improve the tolerance or which spoil the tolerance or decrease the tolerance. It is one among the most common reasons to seek physician's help. Cancer pain management, Ayurvedic modalities. Now, if we think of the different upakramas which we can use, thanks to Shashtir Upakrama by Sushrita, who is the foremost surgeon, use of Vata Vigridihara Chikitsa. All Vata Vyadhi Chikitsas, there are some methods which can be adopted for pain relief. Use of Vedana Stavanagana, Shulahara, Anga Marda Prasmanaganas, etc. in the treatment. Now, Vrana Vedanahara methods also among the Shashtir Upakramas for Vrana, Alepa, Utkariga, Upanaha, Snehapana, Vamana, Virechana, whenever it is possible, I am telling you. Ashtavida Shastra Karmas, Visravana, Shodhana, Ropana, Vasti, Dubana, Krimigna Kriya, Nasya Karma, Kabalagraha, Gandusha, Dhumapana, etc., especially in ENT or the head and neck cancers. The Arhada has to be seen, and these are all the modalities which can be. Sadhyovrana Chikitsa Vidhi is also to be remembered in such conditions. Cancer pain management, anti-cancer treatment modalities, symptom relieving drugs, physiotherapy, psychological counseling, nerve blocks, dorsal column stimulation, transcutaneous TENS, it is called, electrical nerve stimulation, intrathecal and epidural injections, pituitary ablation, percutaneous cordotomy, cryosurgery, lasers, acupuncture, massages, etc. So why I am mentioning this? Because we are in a situation in a new current era where there is high advancement in the modern sector, and we have to be knowing them, and when properly integrated along with Ayurvedic, these methods also tend to be having synergistic effect. If they are utilized alone, they may have some effect, but if it is utilized with the Ayurvedic intervention also, it has more synergistic effect. Now, whose three-step analgesic ladder? That's what I mentioned earlier. That is strong opioid and or non-opioid adjuvants, weak opioid plus a non-opioid adjuvant, non-opioid and a or adjuvant. So it starts from below. There is a ladder, like you can see that. First step is non-opioid and with adjuvant, then weak opioid, then strong opioid. So morphine treatment, everyone would have heard. The government is giving morphine on license basis. I would like to mention one thing, that here we can actually, our forefathers, they were using more of the ahifena for pain relief, as well as ganja for pain relief, vijaya, which is an ingredient in many of the medicines which are made for such purpose. But nowadays, because of the legal issues and other things, even Lagu Marma Gudiga, which contains opium, it is difficult to make without proper license, etc. We know that Ahivena Asava, that is also, so anything containing such things. So I think it is a time when all the gurus as well as the organizers discuss and give a representation to the government that in a permitted basis, with license basis, all Ayurveda Vaidyas who are treating cancer pain also can use these things. Now, I would like to introduce my trial drug, that is the Rasagandhi Medugu, a herbomineral compound formulation used by Ayurvedic physicians of Kerala to treat chronic diseases, including very severe Vata conditions, originally mentioned in Siddha text Pulipani 500. Indicated for broad spectrum of diseases, regimen to be followed during administration comparatively less, safe, cost effective, good shelf life, and other qualities of rasa drugs like less dosage, quick effect, etc. So it is a situation where you see that better, it is not to be used for a very long time. So we have a window period where the patient is waiting the death and you have to get relief. So if the effect of the treatment is much more than any other consequences or side effects which may see in long-term effect, that is not going to happen also. So these Siddha texts, even Pulipani, everything is available in Kerala in the Malayalam format also, many of them, for your information. Medugu preparation resembling Guda preparation with consistency of wax. So it is called Medugu, and in Malayalam and Tamil, Medugu is called wax. So consistency of the medicine is on like a wax. It will be like Madhu Chishta. So it belongs to the Guda preparation in Ayurveda, where along with Guda, the ingredients are put and pounded to make a lehya-like thing, like Sambal Manibhadra Guda, etc. Two modes of preparation, Araipu and Churuk. Araipu method is used here. So Araipu is what I told thee, with a mortar and pestle you do that. Churukku is when we make a paka, and then, or when you do the difference between Guda and Lehya. Rasa Gandaga, Rasa Karpura, Haritara, Kantaloha, Tutta, Karpara, Pradarashrangi, and 40 other herbal drugs pounded with palm jaggery and white of the egg, adding white of the egg. So here you can see that there are two methods of preparation to make it more safer. These Rasa Oshadis, which are Pashana Varga, has to be, Shuddhi has to be done to an extent. But very, very, very smart Vaidyas, who can make the dosage very well, they do it directly also. And so that is why Patya has to be followed very clearly. And it has to be taken in such a way that it does not come in contact with the mucosa sometimes, because once it comes in contact with the mucosa, it can cause, so in the buccal mucosa. So many times it is put into a ball of jaggery and then that is swallowed. Now, clinical research part of it I think many of the Shishas will be interested. The study made use of an experimental approach. The research design selected was one group pre-test and post-test design. So small group was selected, pre and post-test design was followed. Patients were selected at the Pain Clinic Regional Cancer Center Trivandrum, which was one of the settings of the study. For closer observation, some patients were admitted in the Shalya Shalakya ward in the Government Ayurveda College Hospital, Tirunelveli, as inpatients. Study population on the study was adult, terminally ill patients with advanced cancer of head and neck, oral cavity referred to the Pain Clinic. The period of study was 7 months. Sample size and data collection. The sample for the study consists of 20 patients classified into 10 in the compliant group and 10 in the non-compliant group. The technique for data collection was interview, and the tool used was a structured interview schedule. So all the formats were made, and that it was done. The patient's demographic data, data related to disease, data related to pain, assessment of pain and response to the trial drug, laboratory data, etc. were collected. Drug administration and assessment. The drug was administered in the form of capsules. So I told that to avoid the contact in the buccal cavity, it was capsulated 500 mg 4 times daily for 2 weeks, 6 weeks. So here see that the dosage was fixed as 2 grams per patient. Because of research activity and all, we have to fix the dosage according to the size or the weight of the patient. We were not able to. They were put into capsule, and capsule for 1 week was given with instruction. Assessment was done every week on Thursday in the pain clinic in the Government Ayurveda College Hospital for those who are admitted there. So there were patients in the pain clinic of the RCC as well as here. At the end of the study, the data was analyzed with the help of medical statistician. The student's t-test was employed to test the significance. Sorry. The analysis showed that the alternate hypothesis is correct. Thus, the null hypothesis is rejected. Here, that is, it was found that Rasagandhi Medigu was good in controlling the pain. The analgesic effect was there in terminally ill cancer patients. Now, the distribution of the patients by age, distribution of patients by sex, distribution of patients by occupation. There were farmers, there were merchants, there were 5 housewives and other profession also. Now, by the site of cancer, this will be interesting. Buccal mucosa 6, tongue 4, oropharynx 4, lower alveolus 3, palate 2, floor of mouth 1. So those who are interested, this is the way the head and neck, mouth cancers or oral cancers are classified. Now, new classifications also have come. Distribution of patients by stage of cancer at the time of diagnosis. Here, one thing I tell that in RCC and other places in hospitals, sometimes a stage 1 patient itself will be not fit for other treatments. So he will be also into palliative training. Stage 1 was 1. Stage 3, 11 patients were in stage 3. Stage 4, 4 patients, and unknown stage. Their classification cannot be or staging cannot be done, 4 were there. Distribution of patients by histological diagnosis. Well differentiated squamous cell carcinoma 4. Mildly or moderately differentiated squamous cell carcinoma 3. Poorly differentiated squamous cell carcinoma 4. Squamous cell carcinoma other than the 3 and unknown 6. So all these things I am telling because that will give an overall view of how the patients were recruited and taken for subject study. Distribution of patients by presence of ulcer. Now this is very interesting. Ulcerated patients in the buccal cavity 13 were there and non-ulcerated were 7. I'll come to the discussion, then it will be interesting. And face and cheek 13, neck 7. Site of pain. This is the site of pain. Even though we can see that the area of the affected area will be 1, the site of pain may be different also. So we can see that face and cheek 13, neck 7. Now, distribution of patients by type of pain. Sharp pricking pain was there in 13 of them. Stabbing pain was there on 3 and others 4. Here, because it was conducted in a regional cancer center, I have not classified them into Shula, Toda, etc. But sharp pricking pain means it's a Toda, stabbing pain, Vyatha, etc. Now, distribution of patients by radiation of pain. Radiating, there is in 12 people, it was radiating pain and localized in 8 patients. And when we classify the pain in baseline pain severity, severe pain was there in 5 and moderate pain in 5. So more than mild it was in all the patients. Then distribution of patients by non-compliant group by baseline pain severity. 7 had severe pain and 3 had moderate pain. So distribution of patients by severity of pain on final assessment in compliant group. When we see that, when it is, you can see that a baseline pain, severe pain, 7 patients had, I'm telling in the compliant group, moderate group, moderate, 3 were there. But once the medication was given for 6 weeks, then we can see that final assessment, their severe pain had reduced to moderate pain in 7 of the patients and to mild pain in 3 of the patients. So how it works and all, that is a different question which has to be addressed. I will, in the QA session, I may be able to give that. Now, distribution of patients by severity of pain on the final assessments in the non-compliant group. In non-compliant group, because the non-compliant group is the one who started the treatment but could not finish it. Maybe 4 weeks, sometimes 3 weeks, sometimes 2 weeks only like. So severe pain, 3 had and moderate pain, 7 had. So main pain score in compliant and non-compliant group before and after treatment, you can see the p-value in compliant group is 0.001. So p-value, those who are interested in statistics can go through this. Mean score pain before the trial 2.5, mean score after the trial 1 point, reduced to 1.7. Whereas the non-compliant group, non-compliant is the group of patients who could not complete the trial. They left off in between, or they sometimes they were not able to continue the medications due to some other reasons. 2.7 to 2.3. Now, ulcerated patients, mean score before trial was 2.6. After trial, it was 1.9. So, when ulceration, pain due to ulcer also reduced. Non-ulcerated, you see that 2.5 became 2.1. Here, non-ulcerated patients includes those patients who had lymphedema, very pain due to pressure pain due to lymph and all. When the lymph gland reduces in size, the pain also reduces. So conclusions, Rasagandhi is an effective pain relieving agent in patients who are terminally ill with advanced arbuda of the head and neck cancer or oral cavity cancer. It showed some objective changes in the lesion. That is also, I would like to tell you now that after the 6 weeks, some of the patients we admitted in the Ayurveda college, those who had this Kavilvarpu, like even after radiation, they have a scar tissue formed there. And we did our Pranachikitsa apart from this one, so that even the scar tissue was shed off and then new granulation tissue formed like. So our Pranachikitsa has a very big role in these conditions. It helped to maintain the performance status of the patients. It was well tolerated by the patient and it had no adverse effects in the administered dosage. Now, during this period, the renal function test and the liver function test were done. And only in one patient there was a variation. He developed itching also. So other things within the 6 weeks, that is 2 grams per day, after the follow-up, after 20 days also, or after 1 fortnight, there was not change. Ayurveda has a major role to play in treatment and care of Arbuda or cancer patients. So this is what a small conclusion we have made. And limitations of the study, we have to accept the limitation, the small size of sample size to draw generalizations. The short period of study which limited long-term observation and trial with alteration of dosage. So if we alter the different doses, what will be the effect? If it is on a long-term basis, like not once found that there is no toxicity, it can be given on long-term also. So what will be the effect, etc. Non-compliance to therapy due to general lack of knowledge of intake of pain medication and Ayurvedic treatment. Of course, some of the patients after starting on this therapy, they dropped out because somebody recommended that no, you should not take Ayurvedic treatment along with, or some of the neighbors influenced that this will be harmful, etc., etc. Irregular clinic visit by patients due to long distance and poor health. It is a very, very pathetic situation. A 40-year-old cancer patient with two small children going to school. So they may not be able to comply with our instructions, poor economic status and lack of family support. Here I remember Acharya Ardra Sandhanada Tyagaha Kayavak Chedasandamaha Swartha Buddhi Pararteshu Sadvurtam Samasaditi Sadvurdam. We know that many a times we will be want to help, but in trial like this, we will not be able to or permitted to help also. So that is also medicines was given free only, but still they were not able to come and collect in some way. Now recommendations, this is the thing which I can do. A standardized tool for assessing pain should be evolved as far as Ayurveda is concerned also. Rasagandhi Meduga and other herbomineral indigenous drugs should be made easily available. There are so much of restriction coming now. Mercurial drugs, even the use of mercury in our rasa preparations. So government should take a decision in solving all those problems. They should be prepared in a form with convenient, which is convenient to administer. A general question which is addressed in Ayurveda to make it more convenient to administer. Pain clinic cancer care center should be started in government Ayurveda hospitals or at least in collegiate hospitals, so that every Ayurveda hospital, collegiate hospital has a palliative center. Then there can be cancer palliation also, all other disease palliation also. Pain clinic can function along with that. That will help in creating an awareness of the problem among the Ayurvedic medical personnel. Many times we are not informed of these things. So this will help in addressing ourselves the problem and find solutions. The suffering patients will get continued support and care from them. Training in palliative care should be imparted to all medical practitioners. We talk about Apya Chikitsa, but sometimes we see that it is just mentioned only. We have to read through the Indriya Vijnana, the Sadhya Lakshana, the red flags, and where the red flags are there, whether Ayurvedic intervention can remove that red flags, and if still the red flag is there, then how we should be adopting integrative medicine for the sake of the patient. So these are the recommendations. Regular planned teaching programs and instruction manuals should be made available for the patients attending pain clinics and cancer care centers. What Ayurveda can do, that should be informed. Handout should be made. The contributions of Ayurvedic and other systems of indigenous medicine should be understood and appreciated while planning and setting up cancer homes or hospices for the terminally ill patients. I would like the authorities in Ayush to take up this cause, and it will be, if it is introduced in some centrally sponsored scheme also, it will be good. An Ayurvedic approach of total care of the terminally ill cancer patient should be developed. So it is not just cancer pain management, it has to be total care of the terminally ill cancer patient, which is done very well in some of the centers, which should be developed. Suggestions for further study: the same study may be repeated on a large sample with a varied dosage. It can be conducted for a longer period so that more numbers of follow-up and reassessments are possible to determine the long-term effects, because we cannot rule out any long-term effects without studying that. Studies can be conducted with other indigenous preparations which are claimed to be equally effective in cancer and cancer pain. There are many other medicines which are good in cancer, so we should try that. Studies can be conducted in cancer patients having disease of earlier stage of find out their curative efficacy. So cancer patients having disease of earlier stage, when we find that there is effect in the terminal stage itself, then surely it can be conducted in earlier stage following the ethical committee's approval. Multi-therapy approach utilizing the different therapeutic measures of Ayurveda should be tried in cancerous ulcers and Arbuda Vrana. Here holistic treatment means that it is not just one medicine, but all the possibilities of Ayurveda in the holistic way has to be planned. Implications: treatment of Arbuda patients and their palliative care should be given importance in Ayurvedic medical practice, as the indigenous medical systems are generally found effective in combating many chronic ailments. When we see acute ailments, modern is helpful. Chronic ailments, most of them come for Ayurveda. So, even in taking cancer as a chronic problem, cancer pain as a chronic problem, we can do that. Should be given training in palliative care, pain assessment, and management. More intensive interdisciplinary cooperation and collaborated studies should be conducted to establish the efficacy of Ayurvedic therapeutics so that the suffering man is benefited. This is the ultimately Adrasya Prashamanam or Vedanas Prashamanam Ruk Pradikriya is the Chikitsa. We have to do that. And at last, this is my last slide. Finally, as Sydenham in 1966 told, finally, the physician should bear in mind that he himself is not exempt from the common lot. He is a human being, but subject to the same laws of morality and disease as others, and he will care for the sick with more diligence and tenderness if he remembers that he himself is their fellow sufferer. Actually, everyone, we Bishaks, Vaidyas are also sometimes on the other side of the counter. That is, we also become patients. So we have to, Swartha Buddhi Pararteshu, it should be there when we are treating patients with cancer pain. We should be offering the best of our sympathies, best of our medication, best of our all possible things to relieve their pain. So with those words, I thank you very much for the opportunity. Thank you very much for listening, and I am ready for any discussion or questions on this subject. Thank you very much. Thank you, Dr. Garima. Thank you.
Thank you, sir. Is anyone having any doubt?
I think I was able to open up a arena of for discussion regarding the cancers, Arbuda, and the concept of pain, the concept of total pain, cancer pain, etc., and also a clinical study, which is a very preliminary study. And I thank all who cooperated in this.
Do anyone of you have any questions?
Sreevaths, very good presentation. We are grateful. Very
Thank
nice
you.
and very
Thank
nice
you,
and good presentation.
One thing, this subject, a subject हमारा परिव्यू में आता है holistic medicine, that too physical, psychological, and this one. That's why I feel that we will be good physicians in cancer because we have Yukti Vipashraya, Sattva Vijaya, and Daiva Vipashraya approach in these conditions, which are sometimes Karmaja Vyadis also. I would like to get your opinion, sir.
रस चिकित्सा में सर क्या देते हैं? शास्त्रीय मेडिसिन में रस चिकित्सा में हीरक भस्म वगैरह का प्रयोग कितना करते हैं? हीरक भस्म है, स्वर्ण भस्म, इनका प्रयोग करते हैं हीरक भस्म वगैरह का? हीरक भस्म अलग से देते हैं, हीरा का योग देते हैं कोई?
Oh, we have plenty of opportunities to use many medicines as well as Kriya Kramas also. Even our small Vasti Kramas also will help. But as we see that in a research module, we will not be able to do that. So many of the successful practitioners who are treating cancer now are using all the modalities, I think, sir.
Yeah. बहुत बहुत धन्यवाद सर.
Thank you.
आदरणीय त्रिपाठी जी नमस्कार.
नमस्कार शर्मा जी, नमस्कार सर. नमस्कार.
नमस्ते सर.
सर बहुत अच्छी आपकी जो है ये टॉपिक था, बहुत ही अच्छा आपका ज्ञान रहा. वेरी थैंक्स सर.
नमस्ते सर. नमस्ते.
नमस्कार सर.
It is all blessings from all elders, sir.
सर बहुत अच्छा आपका नॉलेज, बहुत अच्छा आपका जो प्रेजेंटेशन.
Thank you, sir. Now we conclude the session. On behalf of the organizing committee, I would like to thank Dr. N.V. Sreevaths sir for delivering such an insightful lecture. I would like to extend my sincere gratitude to our mentor, Vaidya Devendra Trigunaji, President GBRAV, for his continuous support, guidance, and blessings. I thank our director, Dr. Vandana Siroha ma'am, who is the guiding force for all the events at RAV. I would also like to thank Vaidya Rajesh Kotecha sir, Secretary, Ministry of Ayush, for his participation and encouragement in all our endeavors. Most importantly, I would like to express heartfelt thanks to all the gurus, shishyas, and other scholars who, with their presence and active participation, make this webinar a successful one. Last but not the least, I thank each member of REV organizing team who worked behind the stage to make this event successful. Thank you, sir.
Thank you very much. Namaste. Namaste to all.